I'd like to introduce you now to the speaker for our next session. And I think she's here. Yes, hi, Laura. So I'm delighted to welcome Laura M. Perryman, MD, and she's the founder and the director of Dry Eye Services and Clinical Research at the Perryman Eye Institute in Seattle. Laura is an ophthalmologist and a dry eye expert, and we all know her as the doc with heart. I'm delighted that Laura is going to join me for an Ask the Expert session where we're going to explore some of the most common questions that patients ask us when they come into our clinics. But first of all, Laura, thank you so much. I know it's silly o'clock for you. You've got up really, really early for us, and we so appreciate putting an event on like this across the time zones that you've been able to join us. So thank you so much. And wasn't Rebecca's talk amazing?
Go ahead. Sorry, keep going. You're doing great.
Okay, so Laura, let's start our session off. Let's try and really understand what's going on in dry eye for patients that maybe have they've just been told they've got dry eye. They've seen their doctor, their optometrist. Tell me, how do you explain to a patient what's going on with their eyes? And actually, let's rewind a bit, actually, because I know what I was going to ask you. What got you interested in dry eye in the first place?
Well, I guess that's a good place to start, actually. It's awesome to be here, and hearty congratulations to you and your entire crew for putting this on. I appreciate it and respect it so very much. Like this is advocacy in action, right? And I'm just like blown away by Rebecca's presentation and her incredible work. And I mean, she's amazing. So I'm delighted and honored to be here, and thank you so much. I suffer from dry eye myself. And so I get it on a different level. Like, yeah, there's the science, which I think is super interesting, but I'm also a patient. I also suffer from the condition. So I think that gives me a little extra insight, definitely some extra compassion. I've been through some very serious medical conditions, major surgeries, hospitalizations, unrelated to my dry eye, but seems like it kind of exacerbated my dry eye. So I've walked the patient experience a lot in my life, and I bring that with all kinds of respect and compassion and room for the significant strain on us biopsychosocially. That's how doctors call stress and anxiety around your dry eyes. I try to bring that to everything I do to address dry eye for our patients. So that's how I got into it. I'm a molecular immunobiologist by training. What is that? Like, I worked on, prior to med school, I worked on Enbrel, bringing really smart, targeted anti-inflammatory interventions to patients. So that idea of inflammation being the driver and clever ways to address it with precision is what engages me on an intellectual level. And I love bridging those worlds between the patient experience and what's happening in the hardcore science, and creating conversation and literacy across all those different silos, just like this is creating conversation across all these different silos. So hats off, respect to everybody here.
Oh, and we're just so grateful you're here and you've joined us. But you do have such a wonderful way of communicating. I think when you suffer as a patient, it helps. But I've listened to so many of your talks. I've learned so much from you as a clinician. But the way you explain things is so clear, so easy, so gentle. So that's what I hope we're going to tap into now. So how do you explain to patients for the first time they've come to you that they're really struggling with the discomfort, the pain, the anxieties? How do you break that down into a language they can understand? How do you describe it to patients?
Right. So to your point, and much to the theme of everything we've talked about so far, is just how heavy that anxiety burden is, that worry burden is, and you can't. It's human beings can't take in more information when you're in that activated psychological state. And so it's really important to establish a connection and acknowledge the anxiety, like call it out. It's an elephant in the room. Let's talk about this for a second. And that is this is a safe place to talk about and share those feelings, and just naming it and sitting alongside the patient and deeply listening, I think helps to break through some of that anxious static. And now we can really communicate, because sometimes in the course of hearing someone's story, I'll hear like little clues that help me identify some of the main drivers of their particular constellation of dry eye symptoms and exacerbators. So really that story listening is a very critical part in explaining it. Patients need to feel heard. And I think Rebecca's data is incredibly impactful in proving that they need to feel heard. And everything we do in the dry eye clinic is set up to facilitate this as much as possible. We slow everything down. It's not a 6-minute in and out. Patients get an hour, right? We'd start off with a telemedicine and really deep dive in the medical history. And within that detailed medical history, detailed medicine list, I start to see clues as to what's going on. And then I integrate all that information into an integrated treatment plan, modifying risk factors where we can, pivoting and adjusting around ones that we can't, and developing an integrated treatment protocol. Now, explaining what dry eye is, back to your question, that was a long-winded answer, sorry. So back to explaining what dry eye is, it's basically like a broken rheostat in the room that you're in. That temperature gauge is constantly monitoring what's happening in the room with the temperature, sending a signal back to the apparatuses, and then whether it's AC, heat, or more cowbell, whatever it is, that's the signal that comes to the ocular surface to maintain homeostasis, meaning same state. This system is supposed to work without awareness, without discomfort, without visual change, and all those things are abnormal when it comes to dry eye disease, and it's centered around inflammation. And so when I talk to my patients, I'll say our goal number one, first arrow I'm going to pull out my quiver is, what are we going to do about inflammation, right? We've got to get that under control. And now we can start to unravel all the other pieces, working towards physiologic restoration, working towards getting the system back online so that you can have comfortable eyes and stable vision.
Yeah.
It's about restoration.
Yeah, no, that's great. I love the way you use the thermostat, the rheostat on the wall. I think that's a great analogy. But patients often say to me, is it anything I've done? Have I made it happen, or could I have prevented it? I mean, what are the risk factors? What do we should be avoiding? What should we be trying to do to help us out?
Right. So that's a big question as far as risk factors. And it's not uncommon to encounter a patient who feels a lot of guilt and shame, and it's very important to clear that out. It's like there's no shame in this game. Self-blame doesn't serve us here. It is what it is, and we'll regroup and adjust. So create some grace and space around that. Let's get started. Let's roll up our sleeves, right? But just clearing that blame burden is so important. It's critically important for patients to make progress. But you asked, what are the risk factors? The list is really long, and it goes on for pages, right? So that's one of the reasons why dry eye is so darn common, is because so many things can contribute to it. And let's just start off with our age, gender, hormone status, lifestyle, hydration status. I practice what I preach. I do 8 of these a day. Yeah, right. Practice what I preach. Medications are a big exacerbator, right? The simple act of doing an oral antihistamine because your eyes are irritated, you think, oh, it must be allergy. That can actually make your problem worse. The oral antihistamines decrease your lacrimal gland's ability to produce tears and impacts negatively the goblet cells. The goblet cells are, I call them the superhero of the ocular surface. They're like this Clark Kent, and they're just they're modest and demure, but they can whip out a cape and take care of business if needed, right? So those are goblet cells, and that's why we care so much about them on the ocular surface. The goblet cells then, I lost my train of thought. It's really early here, and 2 weeks of meetings back to back, and I'm ADHD, and it's worse after menopause, which is another risk factor. Wait, we're talking about risk factors. Got it. Okay. Sorry. So risk factors and also include prior surgeries. And to Rebecca's point, her symptoms started the day she had refractive surgery. That is essentially the equivalent of taking that rheostat and ripping it off the wall, right? Now the corneal nerves can't tell the brain, hey, can we make some adjustments in the tear quality here? It's a little windy, it's a little dry, it's a little whatever this is. Surgery is another risk factor. Things like Accutane, right? It's great for clearing the skin if you have cystic acne, but oh boy, is there an untoward side effect on the critically important meibomian glands. We can coax a lot of function back out of them. And I think that's another fair thing to talk about is meibomian gland dropout. It can happen with contact lens wear, chronic dry eye disease, rosacea, Accutane, even the eyelids not closing all the way is a risk factor for meibomian gland dropout. Also screen time, right? So all these things are risk factors for meibomian gland dropout. That's quite a list, but I do take all of that into consideration. I'm looking for all those risk factors because in my mind, as a clinician, I'm categorizing, okay, which ones can I modify, which ones are non-modifiable, and that becomes integrated into the treatment plan.
Yeah, cool. So we know it's a complicated disease to manage because there's so many risk factors, there's so many things going on. We know it's multifactorial. Why is it that there isn't a magic cure? Why, if I give my patient a bottle of eye drops, so if they've got conjunctivitis, I can give them a bottle of antibiotic eye drops and it'll clear in 7 to 10 days. Patients come back to me and they say, I finished my drops, it came back, it didn't do the job. I talk about managing dry eye disease to my patients a lot. I try and explain that, there's no magical cure, but, how do you address that? How do you explain to patients that it is an ongoing thing and that we're just managing it and we're, managing it every day, day to day, forever?
Right. Oh, that's an amazing question. And I'm going to try to answer it as best I can because there's a lot wrapped into that question.
Yeah, I'm sorry.
It's okay. We'll get there. I think the easiest way to understand why there's no fix or no cure is to go back to the fact that dry eye is centered around inflammation, right? So your body has a pro-inflammatory arm and an immunoregulatory arm, and typically they're in balance. When it comes to dry eye disease, there is innate immunity. That's like the reflex arm of your immune system. Whoa, there's an invader. Sound the alarms, right? There's the innate immunity, and then there's the adaptive immunity, or the smart arm of the immune system, where it becomes targeted, specific, like antibodies to bacteria or virus or whatever this is. That conversion to adaptive immunity, the immune system never forgets. And so it doesn't take much for those T cells to get revved up again and to start spitting out their toxic inflammatory cytokines, and it makes the goblet cells sick, it makes the meibomian gland sick, it makes the corneal epithelial cells sick. It's like being in a smoky bar and not being able to breathe. It's just like we got to clear up the air, we got to clear the air, we got to clear the inflammation. There's and then you have to remember one other thing. At one point, that person didn't have dry eye. So it's chronic and it's progressive. And once the immune system gets rolling, it feeds upon itself in a double vicious circle cycle. And so again, that's why we focus so much energy and attention on controlling inflammation on the ocular surface, whether it's coming from the lids, from rosacea and meibomian gland dysfunction, or whether it's coming from the body, an autoimmune disease, evaporative stress from being at the screen too much, it doesn't really matter. All those things generate inflammation. That's why we have to focus so much on it. And I wrote a paper, a review paper. It's super high nerdage, but it might be interesting. When it makes my brain happy. The simplest way to think about it is initiation of inflammation, amplification, recruitment, and damage and self-perpetuation. There's no off switch in that once dry eye gets going. The system forgets to return to immunoregulation and to rebalance. That off switch is broken. Mother Nature didn't program that in. She didn't know we'd be spending 100 hours a week in front of a screen. And so I think when we learn, as we develop more clinical tools, we'll get better and better at heading that inflammatory cascade off at the pass, and we'll be able to make some real headway in addressing that inflammation part. That was a long-winded answer. Did I get to what the meat of what you were asking?
Yeah, it was a great answer, actually. But you mentioned screen. You keep coming back to screen use as a driver of dry eye and MGD. So where does all that fit in? Why does looking at a screen give us dry eye and MGD? And what is MGD? What is this link between screens and dry eye?
Right. So let's try to answer that. I actually was skeptical when people started making the connection between screen time and MGD. And then my friend and excellent colleague Priya Gupta published some work out of Duke showing that screen time impacts the meibomian gland morphology on the on infrared meibomography. So I'm like, okay, there's something there. So if you really want to understand what it is, I don't think we totally know, but it probably goes something a little like this. Decreased blink rate and a inefficient completeness of the blink creates what we call desiccating stress. In other words, dry spots on the cornea. That tripwires the immune system. It's like, whoa, there's a problem here. We need to clean this up. Those inflammatory cells that come back in to clean up the mess don't know the difference between cornea, conjunctiva, and meibomian gland. So they just show up and they start spewing out their inflammatory cytokines, which ends up making the desiccating stress worse. Because once you've got these cells surrounding your meibomian glands, and we have confocal evidence that that's true, that the activated immune cells surround the meibomian glands. They don't go inside, but they do surround them. And you can get those under control with IPL therapy. And we'll talk about therapies in a little bit. But once those inflammatory cells set up shop, so to speak, I call them little mischief makers, Cheech and Chong, Th1 and Th17 cells, and they just create all kinds of havoc and chaos and smoke and drink and generally befoul the place. That once that process gets rolling, then it's chronic and self-perpetuating unless you intervene, right? We have to intervene. And that's one of the reasons why there's so many medications that we have to pull out as clinicians and have to use as patients, is because we're trying to address this this busy, noisy, messy disease state that's absolutely centered around inflammation.
Yeah. That was a great answer. Great answer.
You're asking big, hard questions. I'm
really sorry. Okay, I'll come back down again. Maybe I should come back down to patient level. We're talking about
it's all good. It's all good.
We're talking about meibomian glands or MGD, and I'm going to kind of link that into the paradoxical watery dry eye. What's going on? How do you explain to patients that actually their eyes that are watering could actually be because they're dry?
Yes. So remember that rheostat analogy? Well, imagine if it's short-circuited, right? And it's just like, whoo, sounding the alarms all the time. Whoa, 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 more cowbell, right? I need more tears. That's one way. We can have, so it's a reaction to the dryness. The corneal nerves are activated and asking for more tears to compensate for that dryness. And that could come from your eyelids being open slightly at night. Use a mask. I love the eye seals from iEco. There's I have to wash it every single morning with a very simple soap. There's there's deficiencies in the way the eyelids are. So with age and time, the eyelid position changes. And if your lids are down here, or you've had Botox, never ever get Botox here. There's other places we can put it to help the dry eye patient, but never, ever, ever here, right? So there's weakness in the muscle, so the pump function may not work properly. There could be drainage problems, right? The storm drains where the tears drain might be partially blocked from chronic sinusitis, from trauma, from chronic inflammation. So there's lots and lots of reasons for tearing. I think of it as a mechanical issue, a plumbing issue, and then a reactive protective mechanism that's at play as well.
Yeah. Okay. And how do you manage that? How do you treat that watery eye? Do you throw more drops at it? Do you, what do we have to do?
Right. So I try to figure out why the tearing is there, why the excess tears are there. Is it insufficient drainage? So we do a lot of irrigation of the nasolacrimal duct. Is it the way the face is positioned? If there's too much traction on the lower lids, I'll suggest that they see cosmetics ENT for fillers, just to change that support for the lower lid just the tiniest bit. You can even get the tiniest little improvement in the lower lid position, and that can help with your blink mechanics, right? Sometimes tissue tightening is involved. Sometimes we have to do surgery on the eyelids to correct the way the tears drain. Now that's something I try to avoid because the surgical process can stir the pot quite a bit for a while. So we try to avoid that whenever possible. So I try to identify the source of it. Is it tearing from, significant eyelid disease, like from rosacea, ocular rosacea, significant meibomian gland dysfunction, or is it a bunch of keratitis and corneal nerves are being activated? So I really try to pin down what's going on there, and then address my therapies after I figure out where the mischief is coming from.
Yeah, so it's all about finding what the causative factor is to it. Yeah. So, I mean, you've talked about rosacea a couple of times. Why is rosacea so often found in dry eye? What's the link? What's the mechanism?
Yes, so rosacea is super common. It's more common than you realize, but when you learn to look for telangiectasias, those are ropey, sneaky, tiny, fine little abnormal blood vessels that are on the lid margin, and you need a magnification to see them. But that's a hallmark for ocular rosacea, and it's accompanied by meibomian gland dysfunction. So you can start off as facial rosacea and also become ocular. You can start off as ocular and become generalized facial rosacea, but it's inflammation in the neighborhood, right? The eyelids are inflamed, and that's damaging the cornea. Now there's a compensatory mechanism. The compensatory mechanism is more tear output. And so what you'll see in clinic is patients with significant lid disease, lid inflammation, meibomian gland dysfunction. The inflammatory marker, MMP9, is rip-roaring positive, but their osmolarity is in normal range. So that lacrimal gland is doing all the work. Come on, guys, can you like fix your deal here and participate? Right? It's like a two-person bike and the person in the back's like hanging out, not doing their job. So the compensatory mechanism is the lacrimal gland output, and eventually that fails, and then you end up with a hybrid syndrome. So identifying the eyelid inflammation, identifying the source of inflammation in the neighborhood, because geographically it's a local regional problem, rosacea, and it starts with the gut. We'll talk about diet later. And in fact, Dr. Terrio is going to, and your other guests are going to be talking about the role of diet. But rosacea is a huge contributor to the dry eye, meibomian gland dysfunction, ocular surface disease picture. And we address it with IPL therapy. Intense pulse light is a powerful modality for getting that particular issue under control. If you follow my Instagram, Dry Eye Master, you'll see that there's great cases before and after with IPL therapy. Sometimes you need more than 4 treatments, especially if things are pretty far gone and more severe. Takes more to get there. If you're starting off from way back in the sand pit on the golf course, it's just going to take more swings to get that ball into the cup at the end.
So to tell us a little bit more about IPL, because it's, you know, it's an emerging treatment in the UK. There's, I mean, more places are being able to offer it, but some of our listeners might not know what it is and what's involved. I know you're a great advocate of it, but you know, can we just explain to the attendees what it is and how it works?
Sure. So IPL stands for Intense Pulsed Light. This is a non-laser. It's a broad spectrum intense light. Technology has been around for about 30 years. Dermatology has used it that whole time. We now have 6th and 7th generation platforms with awesome safety profile, and it becomes the mainstay for addressing dry eye associated with meibomian gland dysfunction. MGD is a 6-headed beasto, right? There's 6 heads to it. And you know, Jabba the Hutt, he's laughing at your warm, wet washcloth, right? Like, that's not going to do it. You got to get all 6 heads of the beasto. It's bugs and bacteria like Demodex. I think that's a huge undiagnosed problem. E is altered enzymes, the gene transcription that has to happen in the stem cells to make a quality meibum is incredibly complex biochemistry, and that's impacted by the eye, inflammation. Stasis is sludging of the meibum, that thick toothpastey you know, stuff. And T is altered melting temperature. That's why we do our warm compresses. And then O is obstruction. So 6 heads of the beasto. There's nothing in the toolkit that gets all 6 heads. IPL gets 5 out of the 6 heads. It's not a thermal modality. And this is why we layer on therapies, right? We've got to layer on so we can get all 6 heads of the beasto.
Right.
Yep. And IPL's got abundant medical literature, and we have great clinical success with it.
Great, perfect, thank you. No, it's certainly it's an exciting development, I think, certainly in the UK, that more and more patients are going to be offered. We are nearly out of time, Laura. I've got a couple of questions that have come in on the question function, so that might you might be able to answer us. One is a difficult one, and I think it may be how long is a piece of string, but how long does it take from a meibomian gland to unblock?
Depends. So sometimes if it's late stage, sometimes there's scarring inside the gland, and that's where mask and probing comes in handy. I try to avoid it. I try to give the meibomian glands every chance to function on its own. It's like, and hopefully I'll scare it with the threat of mask and probing. No, I'm kidding. But it's like, come on, guys, pick up the pace here. But if there's obstruction inside, then you're talking a longer time frame to get it under control. But you can, all this integrated stuff, you can get them back online.
Excellent, that's great. Is dry eye a condition that's hereditary?
Ooh, that's a great question. Probably in part. There's your anatomy and the eyelid's ability to protect the eyes with a proper blink. There's the aging process. There's a genetic component to how your body responds. The immune system responds to threats or perceived threats, and the immune system sees dryness of the cornea as a potential threat. So some people just have really trigger happy immune systems, which is why autoimmune disease runs in families. The system is just a little bit trigger happy.
Okay. And this is just one final question. Cyclosporin makes my eyes red and sore. I've been using it for a year, but I'm yet to notice any improvement with it. What would your advice be?
Right. Great question. Happens all the time. The fact of the matter is, and this is something Rebecca wisely said, is there's nothing that helps everyone, right? You just keep going until you find something that helps you. And it's not uncommon to have poor tolerability of certain medications and doing great with others. There's many other options for addressing inflammation with the medications. So I would say keep going. If there's a significant rosacea component, address that separately. But it sounds to me like there's a lot of inflammation, and that drop may not be well tolerated by that person.
So maybe go back to the doctor and see if there's an alternative.
Right.
Yeah. And just a couple more, actually, if we've got time. I have Sjogren's syndrome, and quite frequently my eyes sting using prescribed drops. What other options would there be using both drops and ointment?
Right. So that's a tough situation. The Sjogren's autoimmune patient tends to have much more severe keratitis, much more severe meibomian gland dysfunction. And so the surface is kind of raw. And so it's not uncommon to have tolerability issues with the normal things. And in that situation, I conceptually, their ocular surface is in the inflammatory abyss, and I got to throw them a lifeline. And that is sometimes amniotic membranes, autologous serum, aggressive treatments, IPL therapies, all this kind of stuff. And then you get things better to the point where then they can tolerate the easy stuff. So the fact that there's so much symptoms in response to those things just says to me that the system's pretty raw, that there's a lot of inflammation there.
Yeah, okay, so it's all centered on the inflammation, isn't it? All the time.
Yeah, it's the epicenter. That's a sensitive word on the west coast of the US. We get a lot of earthquakes, but yeah, it's at the epicenter.
Okay, I've just snuck one more in here. IPL has helped my dry eye, but itchy eyes is a huge problem. Pt.2 didn't help. Have you got any suggestions?
Awesome question, because we haven't talked about the immunologic bridge. What's that? So there is now a connection, and I talk about this in my review paper. There's a connection between allergic conjunctivitis and meibomian gland dysfunction, and you only have 4 things in your toolkit to block that immunologic bridge. One is allergy eye drops, right? So if you don't like Pt.2, try something else. Try Bepreve, try Lascap, try some other formulation, right? The pHs vary quite a bit. I don't know if you have topical, there's Zerviate in the US, there's all kinds of different things, and they all have different pHs, different tolerability profiles. Just try some other ones, but you gotta stop that immunologic activation. And then the bridge, we have steroids, we have Lifitegrast or Xiidra. I don't know if you have that in the UK yet. We have IPL actually can help block that immunologic bridge. In fact, there's some papers coming out showing that IPL can help with the allergic conjunctivitis, inflammation, itch, and meibomian gland dysfunction. Cool.
Perfect. Laura, we're out of time. I can't believe where that half an hour has gone. Thank you so much. It's a pleasure talking to you. It's a pleasure meeting you at last, having listened to you talk so many times. I believe you're going to stick around, you can't stay all day, but you're going to stick around a little while and answer a few more of the questions coming through for the next half an hour or so. So if anybody's got any questions for Laura that I haven't managed to get to, I apologise. Type them into the Q&A and Laura will answer them for you.